plenty of time for your talk. Uh, Welcome everyone to Geriatric Medicine Grand Rounds. I hope you had a good week and I hope you're ready for a really fantastic speaker. We have Dr. Daniel Fisher with us today from the Department of Psychiatry and Behavioral Sciences. I know several of you have collaborated with him on research since you have shared interests, and many of you know him as one of the physicians in the Memory Brain Wellness Clinic. Dr. Fisher has deep expertise in the topic he is talking about today, back when he was doing his MD PhD at Northwestern. Is that right? Yes. He focused in this topic area, and he's particularly interested in the mechanisms of why some people get neuropsychiatric and behavioral symptoms in particularly dementia, but other psychiatric conditions in older adults. So he has the basic science perspective and the clinical perspective to be able to really give us a deep dive in this topic. And I personally am always grateful when Dr. Fisher sees one of my patients because they absolutely think he is wonderful, and he does such a great job in clinical care as well. So thank you for taking the time to speak to us today about your area of expertise.
Thanks, Kate. I really appreciate that. I'm excited to be able to talk to you guys today about this area. And so let's dive right in. Mostly, we're going to be talking a lot about clinical management, not as much about sort of hypotheses about mechanism and other things. But if you have any questions about that, either during as we're going through slides, or you want to send me a question afterwards, I'm more than happy. Also, feel free to ask questions during the presentation. I think it'll just be better that way. So I have no financial conflicts of interest to disclose. If you guys know of any to be able to give me, please do. I have a young daughter who has needs, like stuffed animals. All right. So to give you an idea of our learning objectives today, I want you to be able to distinguish between different neuropsychiatric symptoms and dementia and have a basic understanding of how to use an etiological lens to diagnose and treat. I want you to be able to enumerate the risks and benefits of different pharmacological approaches, and then have increased confidence in just sort of promoting behavioral interventions as the first line of treatment for neuropsychiatric symptoms and dementia. So I kind of always start with this slide. When we think about memory loss and dementia, a good clinician is usually thinking about these things, knowing that it's not just memory loss when we're talking about neurodegeneration and neurodegenerative dementias and mild cognitive impairment, but also language deficits, inattention, executive dysfunction, other cognitive challenges. I think that most good clinicians, especially this group, are also thinking about all the other associated things like autonomic dysfunction, motor dysfunction. We think about sort of some of the Lewy body disorders and some of the frontotemporal dementias. But this is what the real picture of dementia looks like, and it's dominated a lot by a lot of other symptoms. Is pretty much any psychiatric symptom that you can imagine can manifest new onset in dementia, but they're incredibly frequent. So if you take Alzheimer's disease, which is the most common neurodegenerative dementia, you're going to see that over 90% of patients will develop psychiatric symptoms, many of them new onset. The treatments for it are relatively sparse, and so additional research in this area I think is very important. But as clinicians, often memory loss is on the front of people's mind, but it's actually the other neuropsychiatric symptoms that often cause the most difficulty in quality of life. It can accelerate institutionalization and losing independence in the home. And quite frankly, those with neuropsychiatric symptoms seem to just do worse functionally, which is not as surprising. So knowing how to treat them is very important. And so I often think of dementia as a psychiatric disease, not just one that's dominated by neurologists. And I actually think that we really can think about it as affecting all parts of medicine. So I'm going to take you guys through a case. We're going to focus a lot on agitation. As I go through these slides, there's going to be a lot of text and things. I'm going to try to give you guys the important points about each slide, but I've made it this way so that those of you who are more interested in the individual data and evidence and some of the individual drugs that we may not talk about in depth, you can get a better idea of what that looks like. But let's take a look at this first case of a 74-year-old woman with hyperlipidemia, osteoporosis, who has memory decline and attention issues. Her family endorses short-term memory issues going back at least 5 years prior to the initial presentation, and also some organizational issues going back 10 years. She's got issues with sequencing and executive function, and her initial MoCA is 15 out of 30. So right out of the box, you guys can see that we're looking at a multi-domain dementia, primarily driven with an amnestic picture. Well, she had a fall with her head injury at the time of the initial cognitive deficit. Subsequent MRIs showed multiple microhemorrhages consistent with CAA, as well as severe white matter hyperintensities and diffuse atrophy with a focus at the hippocampus. Her cognitive profile suggested mostly frontal subcortical deficits consistent with a mixed dementia. And so the idea was that she had signs of vascular cognitive impairment and Alzheimer's disease, as well as having CAA. So complex patient just in terms of the underlying etiology of some of the cognitive and psychiatric dysfunction. Her mood and personality were noted to be different from her pre-decline baseline. So she had no prior psychiatric history, and she had increased anxiety and rumination as well as irritability. There had been some delusions and increases in her demands for attention, especially from her husband. And her husband noted that her temper had been worse, frightening at times. He notes now she tends to rock back and forth while watching TV, but otherwise has no motor deficits. Over time, her behavior started to become more challenging: refusal of care, verbal but not physical abuse, disrobing and wandering. She's also been concerned about people being in the house when no one else is there. She's voiced there's delusions of episodes of physical harm from caregivers that are not substantiated. She's appeared hypervigilant at times and will overreact even a small stimuli like light touch. Angry responses to small stimuli are common, and these behaviors happen predominantly during the day and are more uncommon at night. There have also been occasional falls. So you're getting a sense of sort of also that there is multiple things in terms of her psychiatric presentation that have changed both with anxiety, increased irritability, agitation, and then just her overall reactivity seems to be different, which is harder to place in an exact disease bucket, but is more, I think, of a feature that we would think about for her as a patient. So let's start with kind of the APA guidelines, the Psychiatric Association, for what they talk about. And when they're talking about addressing neuropsychiatric symptoms, they are looking at the characterizing the symptoms first. So timing, severity, frequency, determining if there are other modifiable risk factors, especially pain that can be addressed. So pain is incredibly underreported. When you think about your initial workup, be thinking about even types of pain that may be less obvious. And the American Geriatric Society even has a protocol suggesting treating empirically for neuropsychiatric symptoms with Tylenol, and then even up to oral morphine and a buprenorphine patch. I'm a little less excited about the other two drugs, but the idea of giving Tylenol is relatively low risk. And if agitation is being driven by pain, it can be pretty helpful in those cases. So that's something that you might be thinking about in your initial management. Then the APA guidelines say begin with non-pharmacological management and develop a comprehensive treatment plan. And then they have a number of recommendations about non-emergency antipsychotics, but they don't actually talk about a lot of other drugs. So you can see that even from the American Psychiatric Association, there are not a lot of guidelines from how to move forward. I won't go over the individual antipsychotic recommendations. We'll talk more about the pipeline of how you might think about pharmacological treatment as we keep going. Um, Suffice it to say that behavioral techniques, behavioral interventions really are first line from nearly every society. And there are some things that work better than others. And I want to go over those types of things because I think that this is incredibly important, though admittedly hard to implement with, a limited clinic time. However, when we think about agitation in particular, the things that have been shown to be likely effective in meta-analyses are things that are centered along a few different areas. One, in empowering the caregivers or person or people who are primarily helping the person with um, dementia, helping them in their ways to respond. So validation and redirection are incredibly important. The idea that when somebody with a neuropsychiatric symptom, especially agitation, irritability, um, is voicing their concern, it's important to validate their emotion, their feeling behind it. I can see that's really bothering you. Yes, that's something that we definitely have to worry about. But then redirecting and saying, and let's figure out what we're going to do for dinner, because I think that's important. Oftentimes, that can be more effective than having an argument. And I think you guys probably are aware of all of this, but some of this is reminding the caregivers, because having your caregivers be more empowered is one way to help improve the quality of life of the person with the actual dementia. Other things that you might think about are things that are very sensory and things that get you moving. So massage, touch, and music therapy have all been shown to be beneficial in meta-analyses, exercise and outdoor activities, keeping people engaged. But the things that have really tracked across these meta-analyses are the things that are centered on the person and not on sort of broader ideals of what might be helpful, but going to the individual person and figuring out what they need is most important. So Helen Kales, who's a very good geriatric psychiatrist who talks a lot about agitation, will often say agitation is not a disease. It is a reaction to unmet needs. Figuring out what that unmet need is the best way to treat agitation and most neuropsychiatric symptoms that actually happen in dementia. And so I want to make sure that we stress that as we go into the some of the pharmacology. Things that have not been shown to be as effective are things like aromatherapy, light therapy, mindfulness for caregivers, dyadic interventions, reminiscence therapy, so having the patient sort of remember pleasurable things from before. And then trying to reorient them to reality. Again, once you start to go down those roads of trying to reorient the person or argue with them, you can get into actually increases in agitation. And again, realizing that um, though 71% of elderly nursing home residents received pharmacotherapy, only 12% had non-pharmacological treatments. So this is very important to be thinking about and checking in with, as important as your medications, if not more so. One thing that I think that can be very helpful is the DICE approach. This is just to be able to give you a framework. So this comes from Dr. Kales. It's now, I think, been commercialized in some way. And so while I don't endorse the commercialization, I think that the overall framework can be very helpful. The idea being that you want to describe the problematic behaviors that you're seeing, investigate what else is going on around those behaviors, create a sort of a treatment plan that is holistic, and then continue to reevaluate that plan. I think that can be a helpful way to framework for your appointments if you're dealing directly with neuropsychiatric symptoms. So let's talk about some of the pharmacological management. So antidepressants, despite being relatively poor for treating depression in Alzheimer's disease, are routinely prescribed. And part of the reason why comes from the CIT-AD trial, where citalopram was used to reduce various behavioral symptoms, but had signal for agitation, irritability, and anxiety, and even some of the psychoses and delusions and hallucinations. So this was a very well done trial. The effect size was mild to moderate, but you'll find that the effect sizes for most of the treatments we're going to go over are at best mild to moderate. So this is compared to something like an antipsychotic, a relatively low danger and a low risk intervention that you should be thinking about for as potentially first line pharmacology for psychiatric symptoms that are developing in dementia, but especially agitation. A Cochrane review backed this up. A network meta-analysis suggested that only citalopram is effective, though I think that there wasn't great evidence for the other ones. Trazodone, interestingly, has very little evidence, but I see it used quite often, mostly as in our clinic as a PRN medication, and not as sort of the main thing. And then mirtazapine, I think this is important, did not have benefit for agitation in a moderately sized phase 3 trial. So I see this a lot, and I think that people who do a lot of geriatric medicine know that mirtazapine is supposed to be good for a geriatric population. But when it comes to psychiatric symptoms and dementia and agitation, it may not be actually be your most effective option. Your standard SSRI, Lexapro, citalopram. I prefer Lexapro because you don't have as much issues with that QTC prolongation past 20 milligrams. And then um, sertraline, I think, are much better options than mirtazapine. The other thing that you'll be thinking about is whether cognitive enhancers are helpful. So things like the acetylcholinesterase inhibitors, these are the donepezils, galantamine, rivastigmine. There have been mild improvements, but mostly on large scale psychiatric assessments when they're looking at like 12 different psychiatric domains. Often you can get a little bit of increased agitation with an acetylcholinesterase inhibitor, so you want to use a bit more caution. Memantine, though, may actually be helpful um, for agitation. There's a little bit less evidence, but most guidelines suggest that prescribing these medications specifically to address agitation is probably not the right way to go. Having them on board for the cognitive syndrome underlying it is really what you want to do with these. So antipsychotics, these are used a lot, and the ones that I think that we're often most familiar with is quetiapine. That those are the ones that we often see very often. So these are actually approved for neuropsychiatric symptoms or behavioral and psychological symptoms of dementia in other countries. And while a relatively recent network meta-analysis found that they not one outcompeted another, um, Abilify actually had the most consistent evidence for being effective compared to the placebo. Risperidone had some of the lowest risk, and then when it came to sort of stroke risk, Abilify and olanzapine were found to kind of be best. But you'll notice quetiapine isn't on that list. And KDAD, remember this is where our black box warning comes from. The idea being that there is a number needed to harm of 80, about 87 for the antipsychotics as a class. And that, most of our guidelines for treating older adults suggest against these. So when you think about weighing starting an antipsychotic versus an SSRI, you can see that these antipsychotics come with a bit more risk. And so I often think about them more actually as second line or as PRN. Um, More recently, there have been drugs like pimavanserin, which doesn't block any dopamine, so it's specifically helpful for Parkinson's disease psychosis. Um, but it might have some benefit for those with certain types of severe psychoses and Alzheimer's. However, it hasn't really been shown to reduce agitation and aggression in Alzheimer's disease. So more again for those psychotic symptoms. Brexpiprazole has just been FDA approved for treating agitation and dementia. Um, but I kind of write here, don't be fooled. It's just the same thing as Abilify. It's just packaged a little bit differently, affects a little bit more of the D3, D4 receptors. But honestly, I don't think that it's going to end up separating from Abilify. But it is one that has been helpful in reducing agitation. So that's the first one in the United States that's been approved for any neuropsychiatric symptom in Alzheimer's disease in particular, but certainly agitation and dementia. And then remember that discontinuing antipsychotics, if there's mild agitation but not severe, can actually decrease further agitation. So discontinuing those antipsychotics may also be an important strategy to consider to treat agitation. So let's go back to our case. This patient was trialed on sertraline for anxiety, but discontinued due to diarrhea, switched to Lexapro, and then primary care physician prescribed some quetiapine on top of that. This led her to be drowsy without changes in behavior. So then her neurologist switched her to risperidone, zero point 0.5 milligrams BID plus zero point 0.5 milligrams as needed. Ativan was also added for aggression at a relatively low dose and was used relatively sparingly, but there were still daily occurrences of agitation. So while these initial pharmacology approaches were unsuccessful, a psychiatrist was actually consulted. And on interview, the patient expressed that one of her caregivers had thrown her down the stairs, and that's why she was so fearful. Husband later told the psychiatrist that this was a fixed delusion, didn't occur. Despite this, when that caregiver was left alone with the patient ended up hitting her and the police needed to be called. So pretty severe agitation and aggression here. However, the patient noted she felt very safe with another caregiver, saying that caregiver constantly puts me at ease. I'm at ease with her. Her husband agreed and noted that the caregiver often encourages physical activity, such as walking outside and yoga, and that the caregiver stays calm uses a quiet voice, and redirects successfully. So again, those non-pharmacological interventions really had a huge difference on this patient that was seen to be highly agitated. During the interview, the husband accidentally put his arm on a hand on the patient's hand as he was getting up, and she yelled out that it hurt, really hurt, and physically lashed out at him, even though that was a brief interaction. It was apparent that the husband had just very lightly brushed her hand, and he noted that she's particularly frightful with loud noises, often being on edge. So you're getting a sense of some of the hypervigilance for this patient that you may end up seeing in various of the neurodegenerative dementias. So really, again, a lot of hypervigilance in her presentation. So as we start to move into the third and fourth line drugs for agitation, we start to think about mood stabilizers and anti-epileptics. I'll just point out a couple of things here as the overall evidence for these are not great. One thing is that Depakote is used a lot. I see that a lot in the hospital and CNL services for agitation. It has been shown to be ineffective in Cochrane review, nearly every trial that's ever tried to use Depakote for agitation. It's not really one that I endorse using for agitation or aggression in dementias. Lithium has been tried, but had no benefit in a relatively small to moderate sized RCT. Things that you might think about, though, are things like gabapentin, even PRN can have a small benefit, though trial evidence is lacking. Lamotrigine is one, especially if they had a lot of mood lability before dementia, suggesting that there may have already been psychiatric symptoms before the onset that it were just worsened with dementia. And then carbamazepine is one that's often suggested as potentially being helpful, though comes with quite a bit of monitoring. And so because of that, is not my favorite. The other things you might think about are sort of the noradrenergic blockers. And so there have been small trials for prazosin, propranolol, and pindolol. So prazosin, because it was that approach for psychiatry was developed here at University of Washington, is something that is often touted. It had a really good initial trial. In the larger phase two trials, there was not a response, but COVID greatly impacted the recruitment. So it's unclear if it actually got to the power that it needed. So there's scant evidence for prazosin, but I still think it's something that's worth considering, especially if you're thinking about there being a lot of noradrenaline that's keeping the patient agitated. So with the hypervigilance in this patient, that's something we might consider. And then 5-HT1A modifiers, these are your buspirone, your tandospirone. Um, they have had some evidence. So tandospirone has one open label small RCT, but otherwise there have been some retrospective studies and case reports, despite the fact that buspirone is a really gentle medication and is low risk. It also doesn't seem to have as much efficacy in those with agitation and anxiety in dementia. And so it's not something that I would use first line, but might think about augmenting if anxiety is really the driving factor and I've already maxed out an SSRI. So this patient trialed prazosin and given her strong response to these stimuli, and she gets up to 2 milligrams BID using a dosing schedule of increasing by 1 milligram every 3 days. So that's what was done for a lot of the trial and continues to be done over at the VA, to my knowledge. And during this period, she was transferred to an assisted living facility. Well, 6 weeks later, the facility noted that the transition was difficult, and she was getting better though each day. But the director and the husband noticed that she didn't seem to be as on edge or as reactive as before. And she expressed that she wasn't as fearful, though she was still adamant that she didn't need to be at the facility. The facility director reports she's often exit seeking, but that she's very compassionate with other residents. They've used Ativan 4 times in the past 10 days since arriving, but have not tried any of the risperidone PRN. And so this is something that you guys may see as you see the transition to nursing homes is that they'll often use the strongest medications PRN and sometimes won't use the ones that might be more in between but have a better risk profile. Um, the staff, in fact, noticed that she's more agitated when her husband leaves, so they requested him not to visit for a while. The psychiatrist is uncomfortable with this plan, but instead stresses that behavioral interventions such as validation, focusing on the patient's sense of purpose, could be helpful. And the psychiatrist suggests trying the risperidone PRN. Despite having a good clinical visit, the patient disrobes when assaults staff 2 weeks later. Assisted living facility drops her off at the county emergency department and says she's not welcome back. This unfortunately is something that we do see quite a bit, that if a facility thinks that they are not able to handle a patient, they will just drop them off the ER. I'm sure you guys know this. So let's talk about some more medications. Dextromethorphan with bupropion is now approved for depression. And so it's been looked at. The quinidine or bupropion that would be um, tied to the dextromethorphan is to basically cause 2D6 inhibition. So they're not necessarily supposed to be mechanistically active. Um, and dextromethorphan's already been approved for pseudobulbar affect in ALS in Europe. Um, the randomized controlled trials for these showed some benefit for those with Alzheimer's related agitation in some of the trials, but not others. So it's hard to know if this is going to be an effective option, but it's one that I think you're going to be hearing more about. And then Precedex has been tried. Um, it did have a phase 2 trial that's unpublished, and this has more to do with some issue with reporting adverse events than necessarily having negative results. So it's unclear if this is going to be useful, but it is something that's being studied. And then, of course, the cannabinoids have had some small trials that suggest that some of them may be helpful, um, though THC itself has shown not to be. Um, and then finally, those isn't available yet in the US, agomelatine, which is a melatonin agonist with some 5-HT2C antagonism, actually has been shown to be improve aggression. So our patient was admitted to a geriatric psych unit. They removed all her psychoactive medications and switched her to dextromethorphan 45 with bupropion 100 milligrams daily and quetiapine 25 to 50 milligrams every hour. The patient was requiring about one a day, as well as the Ativan for extreme agitation. When the quetiapine failed, they tried her on Depakote without effect, and her meds were crushed to increase adherence. So she becomes discharged to a different memory care facility. And immediately upon arriving, they asked us for more quetiapine from the outpatient provider. She is put on quetiapine 25 milligrams TID with some extra for breakthrough agitation. And despite this, the memory unit is not satisfied and wants even more sedating medication. Um, the medical director suggests increasing her bupropion, which, as you guys may know, doesn't tend to work as well for anxiety. Unclear if it's really helpful for agitation, but would probably not be super helpful and might make it worse. Um, and the psychiatrist comments it's unlikely to improve agitation, but they keep pushing for it. Um, the facility insists, and so the psychiatrist is ultimately willing to try BID dosing of bupropion, but reminding the staff that the patient tends to do better with a sense of purpose, encouraging them to incorporate some of the behavioral interventions. So again, you can see that as more people are added to the patient's care, it can get very complicated in terms of the pharmacology, and you'll often see this, and it'll be hard to know what might be working and what isn't. And some of the rational choices that may have been made along the way can get lost. So the family director, um, the family and the director of the memory unit follow up 6 weeks later, and they say they've used Ativan almost every day. They want it scheduled. And despite this, the memory unit actually faxes their MAR and reflects Ativan's used about 2 to 3 times per week and primarily was in a 1 to 2 week period. When this is noted to the director, they're visibly upset and call for the charge nurse, who reports the patient as more sexually promiscuous, disrobing and engaging in sexual activity with multiple new partners. The staff even reports that she's taken a new boyfriend, though unfortunately that person is at a lower cognitive status and the staff is constantly having to remove her, and they're concerned about the safety of the other residents. They note that there does not tend to be agitation on the days when her husband visits, and she generally enjoys speaking with him and her daughters over Zoom. It's noted in the MAR that PRNs are always given by two staff members, but never from other staff members who work with the patient. Agitation is always noted to be in the afternoon. Well, the staff requests more Ativan and more Seroquel, or something stronger, they say. The psychiatrist instead increases the dextromethorphan from BID and restarts Lexapro. And the psychiatrist again tries to discuss behavioral intervention. So again, you can see embedded in this vignette, there are things that seem to be related more to the patient's environment that are leading to agitation. She's only getting PRNs when certain people are working with her. When she's engaged socially in appropriate ways, she doesn't have as much agitation. But these things are kind of being swept under the rug for the pharmacology, and I think that happens when we notice really concerning behaviors. We think that, meds are definitely going to be needed, and they're part of it, of the treatment, but it's not the whole thing. So remembering about some of those behavioral interventions can be helpful. So what do we do with inappropriate sexual behaviors? So this does come up in about 7 to 25% of patients with dementia. And evidence for treatment is relatively sparse. But first line, I would recommend looking at environmental and behavioral approaches. So redirection, distraction. Some people have advocated for putting clothes on where disrobing is more challenging, providing other methods of stimulation and sort of engagement to prevent boredom. And then continue just sort of psychoeducation that some of these um, behaviors may be inappropriate or uncomfortable, but may not necessarily be hurting the patient or anyone else, if that is indeed the case. On the pharmacological side, mostly SSRIs are considered, and you guys can think about that in terms of them actually kind of reducing libido, which is why they can be kind of helpful for their side effect in this situation. Um, Other ones have been looked at, like some of the tricyclic antidepressants, like clomipramine, has one positive case report, though, that has significant anticholinergic effects. Antipsychotics have a few positive case reports, but not too much else. For men, thinking about anti-androgens and beta blockers, the anti-androgens I think are can be a little bit more questionable about the ethics, but beta blockers might be reasonable, again, trying to prevent some of the arousal in those cases. Um, but still not a lot in terms of what pharmacology might be most helpful for inappropriate sexual behaviors. Okay, I want to give you guys sort of some frameworks for thinking about algorithms. And so I think that this is one that you might think about from Harvard South Shore. Well, I think that there's a lot of different approaches. I think that this is a great place to kind of think about how you might build an algorithm for yourself. And they break it up into sort of emergent cases versus ones that are more long term. So in those emergent cases, you really want to think about safety. And so you might be thinking about olanzapine intramuscular as your first approach, and then thinking about Haldol afterwards, and then even benzodiazepine. So again, like really urgent, you're talking about like emergency department type stuff. For urgent BPSD, they actually suggest trying Abilify first and getting it up to about even 15 milligrams. And if that doesn't work, considering risperidone, then prazosin, and then ECT. And then for those non-emergent PTSD that you might be dealing with more in the clinic setting, they suggest starting first with optimizing pain control. So again, going back to pain being a driver of a lot of the agitation, and sometimes getting good pain control can help get rid of that agitation. They then talk about sleep optimization, even considering trazodone to help with sleep, especially if they're relatively disordered. Initiating donepezil and memantine if it hasn't already been done as part of sort of standard of care, and then considering something like an SSRI, and then after that, moving on to second generation antipsychotics, they especially like Abilify, then considering prazosin and then even carbamazepine. So again, this is something to kind of hang your hat on if you're looking for an algorithm, and I think that was pretty rationally developed. All right, let's look at some other cases. And I haven't had a chance to check the chat. There's not any questions yet. So, oh, got one in the chat. For sleep benefit, recommend against trazodone in general. Yeah. So there's really good reason for this. So the idea is that sleep medicine says like don't use trazodone, use doxepin. Um, Here's some of the math that kind of goes into that. Um, Doxepin is one of the few medications that's been shown to help with mid-sleep consolidation. So a lot of the sleep aids that are at our disposal, um, we are really good at initiating sleep, shortening sleep, latency to onset. But people wake up in the middle of the night still. And Doxepin was one of the few things that helped to prevent that. So sleep medicine, understandably, likes this a lot for that reason. As you can imagine, even though trazodone and doxepin both have anticholinergic properties, doxepin might be a little bit more anticholinergic, and so it gives us a bit more pause when we're thinking about people who are on the older end of the spectrum, but especially those with neurodegenerative condition. Um, I think that Silenor, which is a 3 to 6 milligrams, is just kind of outrageous in terms of the price. But you can prescribe, relatively low dose doxepin at like 10 milligrams. That's off label, but can be very helpful for sleep. Um, if there's a lot of issues with mid-sleep consolidation, and that's thought to be affecting the overall picture of someone's sleep, and you're not noticing other things that are interrupting mid-sleep consolidation. So often with our older adults, and especially men, it's urination at night and thinking about that. Sometimes just getting on tamsulosin can improve their sleep. But if you notice there's a lot of issues with mid-sleep consolidation, you think that might be contributing to worsening psychiatric symptoms, Doxepin may be reasonable to consider, but you want to, again, just use caution and write like, yep, I know it's anticholinergic, but um, it might be really helpful for sleep there. You want to make sure, obviously, to counsel your patients and the family as well, and looking out for falls and things along those lines. Otherwise, I think doxepin is something that I often would go to if I know that it's not just issues with sleep onset. But if it's just sleep onset, trazodone just has a little bit better of a track record. So that's kind of the long answer for that one. All right, let's move on to the second case. So this is a 55-year-old with dementia, and she's had a 1 month history of delusions that Harry Potter and Hogwarts are real. And these, by the way, I'll mention these are all inspired. All these cases are inspired by things that I have seen in the clinic. So prior to presentation, the patient had a 2 year history of worsening executive function, requiring her daughter to schedule her appointments at work, write her emails, even perform many of the tasks as an FDA officer. The patient often laughs inappropriately and bursts into song spontaneously, but not in any like cool high school musical sort of way. She often lacks empathy and sometimes even puts non-food items into her mouth. So they get some idea of hyperorality and then emotional blunting here. Her FTG PET shows significant hypometabolism in the frontal lobes. So you get a sense of behavioral variant FTD. Um, and Sorry, I was looking at Angela's comment. So her husband reports that one morning he actually found her writing letters to Neville Longbottom, Minerva McGonagall, and Luna Lovegood. And she expresses concern that her owls are being intercepted by the Dursleys. She hopes that some of the shoes in her closet may fit Luna, and she's very worried that the children at Hogwarts aren't being treated well. When asked about this, she partially acknowledges that Harry Potter isn't real and that it's fantasy, but then a second later expresses that she's living under the stairs. By the way, there are no stairs in the house. She sometimes looks out the window worriedly, and when her husband asks why, she remarks that she heard someone around the house who may hurt her. She says it was someone she saw at an airport recently, and the family did just return home from a trip. So here you're seeing behavioral variant FTD, um, but hallucinations, potentially auditory, probably more than visual, but then severe delusion. So again, not everything when you see hallucinations ends up being Lewy body. But how do you deal with psychosis specifically with not when they're not necessarily with agitation, but just if there is psychosis? Well, psychosis often tends to be more visual than auditory in the dementias, especially with Lewy body. Again, more common in Lewy body, but do happen across. Um, and a Cochrane review found that surprisingly typical antipsychotics may have a small effect on psychosis, but atypicals may not. Granted, again, if you're looking at all atypicals, that can be more hard to interpret. Citalopram was found in secondary analysis to show to reduce the frequency of delusions and hallucinations. So it's something you might actually consider as treatment for it. But I think the bottom line is that don't treat a hallucination unless it's distressing or otherwise compromises other aspects of care or puts somebody at risk. There are some people who have hallucinations that are relatively pleasant, or are non-distressing because of the risk that you can do with medication. It's better to simply validate those experiences and validate what the patient's seeing, especially if they're not worried. In this particular case, the patient was. And so this particular patient actually ended up getting risperidone at relatively low doses, no higher than 2 milligrams, which actually really improved the frequency of these delusions and other concerns that she ended up having. And because there was no underlying Parkinsonisms for this patient, it was relatively well tolerated by her as well. So it's like, so risperidone really helped. Again, leaning on risperidone more because it has a higher D2 blocking, closer to those typical antipsychotics without having quite as much risk for some of the adverse side effects. So you get an idea of sort of some of the rational prescribing that you might use based on these presentations. Yeah, Angela.
Yeah, I mean, well, first of all, I just want to say if I do have hallucinations, I hope this is it, or delusions, but watch horror movies, so it's not going to be as great as this. I'm gonna like live in the stand or whatever. But jokes aside, though, I this comes up a lot with my patients with they have fixed delusions, or not even really fixed delusions. It's probably just forgetting that their loved ones are dead. Like, I need to call my mom. I need to call my mom. It's like your mom was dead 30 years ago. And so in more mundane things like that, do you counsel people about, I know there's some like vivid NPR stories about families like going along with it and like, yeah, your owl delivered your mail 2 days ago or whatever. I think some families feel pretty uncomfortable with that. And what I do is I kind of do a middle ground, like, oh, you're thinking about Harry Potter. Tell me more about that. And, or in this case with my patients, oh, you're thinking about your mom. Like, let's get some picture books out. Your mom really liked tea. Do you want me to make you a cup of tea? And really trying to redirect. I don't know if that's helpful or what, if you've heard about that kind of thing. I mean, if they're really, really agitated, like, I need to find that owl, I need to find that owl, I think that's different. But I try to counsel my family to do a lot of redirection, and you can do that without lying. You know what I mean? Like, oh, you're thinking about owls.
Yeah, no, I agree with you there. I think that so therapeutic lying is it's sometimes called. I've seen some families implement that pretty
Yeah.
effectively and are comfortable with it. And it does, I
Because I
think,
mean, the alternative is like, oh, your mom's dead. Like,
right,
that seems really cruel. Or like, Harry Potter's not real. Harry Potter's not real. Then they're just gonna get more mad.
absolutely. So what you're really pointing out here, though, is that what you do is you validate, like, oh, you miss your mom, you're thinking about your mom, and then you redirect. And I agree with you. I
Yeah.
find that to be the most ethical strategy, and I
Uh-huh.
find it to be the most effective in these situations. And that is exactly what I would counsel people to do. That being said, if they come to me and they say, like, yeah, therapeutic lying's worked really well for me and it doesn't seem to harm the other person, I'm not gonna like, I won't say like, oh, you shouldn't do that, try this instead. I'll just be like, I'm glad that's working for you. Uh,
Yeah, I mean, unless they're in Congress or something, it's probably fine to just let it go.
Right, exactly, exactly. Yeah. But I agree with you that the real point here, though, is the redirection part of it. It is, and also the validation of the experience, right? You don't just say like, hey, let's make some tea. You say like, hey, I can see you're thinking about your mom. Oh yeah, your mom loved tea. Would you like some? Right? You when you link it in that way, you're saying like, I hear you, and let's pivot to something else. And I think that as respects the person's autonomy a bit more, and their humanity a bit more, and then I think it does it without lying. And so yes, I agree with you. That's what I counsel my patients if they ask me, what should I do? Um, all right, that was a good question. Let's move on to the next case. So this is a 72-year-old male with hypothyroidism, diabetes, hypertension, prostate cancer in remission after TERP, nephrolithiasis, dysphagia, and dysphonia, who presents with visual and extracampine hallucinations. So these are hallucinations where you feel like there's something present, but there's not anything there. So it's that feeling that's the hallucination. It doesn't necessarily relate to any of the five senses, though. Patient reports that this summer they had episodes where they felt like they were seeing clouds or shapes in their vision, and they weren't distressed by them. But then they began having the feeling like there was a human presence near them when no one was around, and that was mildly distressing. They also note snoring while sleeping, and the wife recently moved to a different bed within the last few years. It's not clear that these hallucinations happen around sleep, however. So you think about people with sleep apnea having hypnagogic hallucinations, um, and that also can be true with certain neurodegenerative diseases. On exam, the patient has hypophonia, right upper extremity increased muscle tone, bilateral intermittent tremor, positive pullback tests, and decreased right arm swing with gait in a MoCA of 18 out of 30. So getting the sense here that there are significant Parkinsonisms. Family reports that there are times when he seems much more fatigued and with much worse cognition, but these periods can fluctuate throughout the day. So there's your cognitive fluctuations when we think about the McKeith criteria for diagnosing clinical Lewy body disorder. We're starting to check some of these off. And the wife reports years of acting out dreams. That is that REM behavior disorder, which is why she moved beds. These have changes that had preceded he has had changes in gait that preceded these symptoms. So when we think about psychosis and Lewy body disorders, right? Parkinson's disease and Lewy body dementias, then we're often thinking about different pharmacology because D2 blockade is dangerous. So to remind you guys, Lewy body dementia occurs when cognitive symptoms precede motor or come on within a year of motor symptoms. Otherwise, if you have motor symptoms first for a year or more and then develop cognitive symptoms, it's Parkinson's disease, mild cognitive impairment, or dementia, depending on their functional stage. Um, and psychosis is really common in these disorders. D2 blockade, dangerous. So do not give these guys Haldol. Put it as an allergy on their list. I'm sure a lot of you do this already. Um, and unfortunately, most clinical trials are done in Parkinson's disease, but not any of these dementia cases. So it's hard to know exactly what to do. One thing that can be really helpful is the cholinesterase inhibitors in these cases. And so they may improve psychosis significantly and have been shown in at least two different randomized clinical trials. Um, it's not clear that this extends other dementias as well. People with Lewy body disorder tend to respond really well to cholinesterase inhibitors. And so they can be really helpful even though for the psychosis, which can be kind of surprising. There are some other things I think you can consider. So in somebody who has a Lewy body disorder, if there are Parkinsonisms and you're concerned, this is where your quetiapine really is your friend because it doesn't have as much D2 blockade. However, it's not necessarily clear that it's beneficial in small trials at low doses. Um, what, on the other hand, it may help with some of the distress from those hallucinations. So even if it doesn't get rid of the hallucinations themselves, if it lessens some of that distress at those low doses, I still think that it can be effective. Clozapine is another thing to consider. Obviously, there's a lot of difficulty with prescribing clozapine in terms of monitoring, though I do believe that the REMS have gone away for that. And pimavanserin is specifically for psychosis and Parkinson's disease, but you can definitely try it. Um, the real world experience is that it often doesn't work as well. But these antipsychotics, as other antipsychotics with higher D2 blockade, can often cause real problems. And so I leave this chart for you guys. I find it really helpful if you're really interested in the individual pharmacology of these drugs. But you can see that the D2 receptor is put there. Um, and to get a sense of, what's the lower D2 blocking drugs and then how those relate back to these sort of recommendations. All right, let's go into our next case. So there's a history of hypertension, hyperlipidemia, hypothyroidism, dyspepsia, visceral hyposensitivity, osteoporosis, and moderate AD with agitation. Patients started having short-term memory loss and mild word-finding difficulties 4 to 5 years prior, and CSF consistent with AD. The family reports that she has high anxiety and abdominal pain that began before her AD diagnosis and has had extensive GI workup. They ultimately concluded visceral hypersensitivity. For this patient, their abdominal symptoms actually preceded, I'll tell you, they did actually precede their cognitive symptoms. Um, she wakes up every morning with concerns of abdominal pain that only subsides when she goes on walks. She has to do this multiple times a day. She's very anxious throughout the day, which coincides with her pain bouts. She often refuses to eat during these bouts and has had weight loss. And she's had multiple treatments, including nortriptyline, sertraline, duloxetine, escitalopram, Xanax, rivastigmine, memantine, gabapentin, cyclosamine, amitriptyline, mirtazapine, peppermint tea, ginger tea, carafate, quetiapine, buspirone, and prazosin. So you can really see that a lot of things had been tried. While some therapies have led to short-term improvements, no therapy has yielded long-term cessation of symptoms. The husband now finds it hard to keep the patient's demands to walk, keep up with them, and he thinks that he can no longer do that. She can no longer walk on her own, is not, and starts to consider potentially the higher level of care for her. So this was a patient where you've tried a lot of different pharmacological approaches. I can tell you they'd also tried a lot of different behavioral approaches. Nothing was working. So remember that electroconvulsive therapy is very safe and effective for our older patients. There are no absolute contraindications, and the side effects, which are mostly just post-ictal delirium and cognitive effects, are transient for our patients. So even in dementia, very safe and likely effective. Um, in depression, relatively safe, likely effective. And they may even improve motor symptoms in Parkinson's. This patient actually did end up getting ECT. And within about 6 or 7 sessions over 2 or 3 weeks, ended up having full remission of symptoms and has been remained in remission for close to a year now, and had a lot of the other medications that they were on go away. So think about ECT and thinking about that ECT consult. We now do have the neuromodulation center up near Northwest Hospital. So the Garvey Neuromodulation Center. There should be a way to be able to refer to that if you think that a number of psychiatric medications have been tried and nothing is working, especially for agitation, but then depression and dementia. TMS, this is another sort of interventional technique. Uh, there have been shown to be some benefits for cognition, maybe in AD. There's a trial going on here at UW. Um, Hard to know whether it's going to be helpful for the psychiatric symptoms in dementia, but there have been some trials that have showed that it might be. So it's worth kind of thinking about, but we definitely need to do some more research into this area. I want to do this last case with you guys, and then I can take any last minute questions. But I think this is an important one to go over too. This is an 83-year-old female with a history of hypothyroidism, chronic DVT on aspirin, um, essential thrombocytosis on hydroxyurea, aortic stenosis, and remote TBI, who had decreased motivation. Husband notes the patient is much less motivated and the whole world has collapsed that she used to do. Patient notes that I just don't have the interest in them, talking about her hobbies. Reduced socialization, and she notes it's because no one listens to me. Husband notes that he's been trying to get her to be more engaged socially, but if he doesn't push her, she doesn't want to do the things that she used to. She denies poor mood, though, and her husband has not noticed any tearfulness or clear dysphoria. She has a family history of late onset dementias, has progressive difficulty remembering names of familiar people, making progressive mistakes while trying to complete complex tasks like hooking as a MoCA of 18 out of 30. Her cognitive issues have been going on for years, but she's also started to show stoop posture, acting out dreams, reduced gait speed, minimal arm swing, hypophonia, masked facies, and visual hallucinations. So you can see this is someone, again, with sort of Parkinsonisms and other key criteria, um, but has significant mood deficit. And the important thing to think about in these cases is whether you're looking at depression or apathy. So these are both very common psychiatric symptoms that develop in dementia, as well as anxiety. There now are some formal definitions for apathy in neurocognitive disorders, which are defined by a decrease in two out of three areas of interest, initiative, or emotional expression. Um, but the thing to kind of remember is that with all the other things that can go on with dementia, you can easily fulfill the MDD criteria if you mistake apathy for anhedonia, and then therefore try to treat with an SSRI, which actually could make apathy worse. Um, this is why it's so important to kind of differentiate between the two, because while it can be frustrating and a source of burden for caregivers that the patient's apathetic, simply having some discussion about this being apathy and not depression can help put them at ease that this is part of the disease. It doesn't necessarily need pharmacological treatment. Behavioral activation, behavioral engagement, pushing the patient even sometimes a little bit can be helpful because often these patients will still enjoy when they're actually doing something. And then you can ask them that. You can say, like, when you are with your grandkids, when you're knitting, when you're, out doing things with friends, you enjoy that. And they'll say, yeah, but you don't feel like you need to. Well, I don't. I'm older now. It's just not as much as a need. They'll always have something that sounds quite rational, especially if they're at the MCI stage, but doesn't quite make sense for, well, then why aren't you? And sometimes it's just this loss of motivation. It's just apathy in and of itself. There are treatments for depression, but famously, your normal SSRIs have not done well for depression, including large trials with sertraline, mirtazapine, um, and to some degree, some of the other SSRIs as well. Um, that being said, in non-Alzheimer's, they've often found to be effective. But there's this question of whether people are treating SS apathy with SSRIs, I think, in some of these trials. For apathy, pharmacologically, there's not a lot of great data. However, a low dose Ritalin has been shown to be effective for improving apathy in Alzheimer's disease without changes in weight. This comes from the ADMET 1 and 2 trials. And then your cholinesterase inhibitors has some evidence, though it's relatively mixed. And then agomelatine has been shown to be helpful for apathy in FTD. The Foxy trial did show an improvement. The only issue with oxytocin and using it more broadly is that it is administered intranasally. Um, and so that can be a little bit difficult to implement with certain people with severe apathy and other BVFTD symptoms. But I think it's something that's going to be really promising. It'll be interesting to see if it extends to being promising for other forms of apathy and other types of neurodegenerative conditions. I'm going to go to just the main takeaways and skip the last case so that we stay at time. But I want to, if there's anything that I want you guys to take away from this, here are the main things. Behavioral interventions are always first line. Be thinking about these if you can structure them into your time your time for an appointment when dealing with a patient that you know is having agitation. It can really pay dividends. Some of these things, if you intervene, it can make the agitation kind of go away. And Bill, I'll ask you to I'll answer you in just a sec. Um, and then SSRIs are your friend unless you think that there's apathy. I particularly like Lexapro, but I think sertraline is also a good option. But they can be helpful for things more than just what you would normally think about them in terms of mood. Oh, gotcha. Um, Finally, antipsychotics do help a little with agitation, but try to keep them low and routinely assess if they're needed. And then finally, if you really are having severe neuropsychiatric symptoms and dementia that's refractory to a number of pharmacological treatments, don't forget about some of these neuromodulation techniques, especially ECT. It can be really helpful. And with that, I'll kind of take questions. So Amy asks a really good question about SSRIs harming with apathy or not helping. Um, and the answer is that we do not know whether it's straight up harm or whether it is just sort of null effect. There have been some kind of smaller trials that have suggested it can increase apathy. I think that anecdotally, just working from patients across the lifespan, There are some patients where if we get to especially higher doses of SSRI, they'll say that their emotional range is a little bit shortened or narrowed and sometimes a little more apathetic. Um, but I think that it's more that it just doesn't help in situations of apathy. And but I don't think that if you try it because you're like, well, I can't tell if this is apathy or dysphoria, but I'm gonna give it a shot. I think that's totally fine. I don't think that you're gonna do irreparable harm. And if it does just make apathy worse, you can always pull the SSRI. Again, other than concerns about I think hyponatremia, which is still relatively rare, though more common in older adults with SSRIs, they're still relatively safe and they're still probably worth a try, even if you're on the fence about it.
Well, thank you so much for this talk, folks. Please fill out